My husband and wait, we're pretty early. Okay, so I know you're in the room, so we're good there. Let me go check and see if you really should be in that other classroom. We'll figure it out.
Okay.
Thanks, guys.
But for now, just tell all the other students stay here, right?
Yeah, I would, if someone comes in, let's just set it up here, at least so I know you've got it set up for today.
Okay, sounds good.
Thank you.
Yeah.
Oh, I lost your audio, hang on. You're cutting out, I lost your audio. Oh, sorry, I missed the wisdom, because your audio was out there for like less 20 seconds. There it is, that's better. Yeah, that's true. I don't know why sometimes that happens. I know, running up that hill is, yeah, well, talking, it's not easy. I guess our office is at Jason's. I'm down at RSLB because I did my ACLS. So I figured it all. Make sure it looks inspired. Rachel, what are you doing?
Oh, yeah. Yeah.
You know,
Should be on the other side, but we'll stay here for a while. Hello. Show me over.
Oh, Rose. I think we were. in the same number.
Yeah, maybe I'm Sophie.
Rose, yeah. Yeah, oh yeah, AMCP, that's right.
Yes.
Good man. How's your training?
How's your phone?
Training?
I'm
You're
good.
going to training, right? Oh, from home.
I'm a lot better now. Way before that.
Yeah.
I was already with 2020.
Yeah.
Yes.
I was there. Oh, you're there.
Yeah.
What's it like? Like 2 hours and a half, 2 hours? Yeah. It's good. I like it. And no, I'm going to stay with them till the end.
Wait, but I'm surprised.
Why? Because you know, I
I guess like.
almost not everything, but I know a lot about the system,
No,
about the stuff.
not for, so
I-
my first year,
and you-
everything was totally.
rotation,
like,
I was doing
integrated
everything,
classes.
like.
And then,
so
like,
it's only
recording the
rotation,
grandfather
it's
on
prescription.
It's okay, it's, but it was old, but I
I
had to
was
go
the
back
beginning guy,
home,
was
and
there,
it was
like,
like a whole
the
thing,
first,
so
the
like,
first goal.
I just, like,
doctor,
I figured that
and
the
I did up the patient.
interaction
Then
fell apart.
something you
And
know,
so
yeah.
I had to retake the final quarter
Yeah, like.
of it,
I do
so I
third
started, so I
body,
did that,
the
and stayed
rejection,
for about
everything,
2 years,
the
and after that, I was like, I
I'm
would
happy
like to
with it.
leave.
Yeah.
I
I never
want
said
to
I
go
want
to
to
Portland.
work.
Yeah.
Like I work
No,
1 week,
I
40
understand, like some
hours,
people
and
like
what you did,
the
man.
quieter
Well, they pursue that.
environment.
Yeah.
I think I registered, and when I need to
Yeah.
leave,
And then there's a
I will
whole
come,
like.
fix it, and I go back.
I like Portland a lot, I'm not from here,
Yeah,
but
so,
from Idaho originally.
in the beginning,
But
I
I
feel
like
bad.
living in the city,
But
you're
right now,
having
it's
things to do.
yeah, I think.
I just think it's, I think it's.
Because it's not,
more
it's not way to learn like what they did in the.
I think 1 year in Corvallis sounds like the
Maybe.
same.
No, no.
I tried, but no.
Yeah.
Yeah. Versus the vaccine, it's chill.
I hope it all just like seriously.
Understand the possibility. What does mean here? We have a picture. We don't have picture first that first. Really? I don't know.
Oh, now is like we have 2 lectures, so one from 12 to one PT, and then from 4 to 6,
Why?
like 2 lectures, because they need to cover like the 2 days.
Yeah.
Which two days, Thursday, Friday?
Yeah, Thursday, Friday, so we're not going to class Thursday.
Oh, we don't have class on the Friday?
Yeah.
Are you sure?
Yeah.
But you didn't mention.
No, he already mentioned in the.
He will? Oh, the syllabus. Read my laptops too. Was it last show? Today.
I think, is.
Or the computer program that. So it's in.
Oh, I just Dr. O's over there.
Yeah.
Oh, he's gonna be here. I mean, that's fine. Sometimes he'll like even ask us questions, so I'd rather he be over there.
Yeah.
You can ask from here actually. If you have any questions or you can ask from here. Like,
Oh, yeah.
you and-
No, he like picks out people, like he'll ask you a question and pick you.
Oh, really?
Yeah, sometimes.
I know that that's good for story. Like I know
I
that
know.
it's like a tested learning style that's like effective for students.
We still love music.
Test. Okay. Good afternoon, everyone, and welcome. Happy New Year, and welcome back. Can you hear me? Can you hear me? Okay, excellent. So since the techs now are working to figure it out how things work, I'm going to take some time to welcome you back. Nice to see you all. I hope refreshed and recharged. I sent an email just a few minutes before that. So as you know, we start with Dr. Ali Olay on the kidney module, and Maddie Moss, our P4.
Okay, sorry.
Rotation? Yeah. Okay. She is gonna assist Dr. Olay and me later on with some of the material. So if you have any questions, just go to Matt. Don't come to us. So she knows everything. So she can communicate better with you anyway. So there are 2 hours today. And on Wednesday now, Dr. Olay is gonna have 4 hours. 2 hours are gonna be 12 to 2 in this room. And then from 4 to 6 are gonna be in 305. I just got confirmation this morning. This is why it's not in the syllabus, but I sent an email. So 4 to 6 in 305. When Friday is going to be here, and Maddie will be your instructor. Next week now, Monday is a holiday. Wednesday, we're going to be Tuesday, Wednesday now, they're going to be 2 hours. And then Dr. Olay is going to have a review optional session again from 4 to 5 to 6, whatever. He's going to be available for questions in 305 as well. And then as planned. So there are going to be 5 exams. So 5 modules, 5 exams. And the last exam, so 6 exams, what am I talking about? 6 exams, and the last exam, for the first time ever, we're going to have it on a finals week. The reason that, so this class, usually we did not have finals week exams, but after request from previous students, they wanted to have more time between exams and between modules. So in order to add this additional time, we have to move your exam 6 in a finals week. So If you have questions, if you miss an exam, if you miss anything, come to me, send me an email. If you have questions related to content, please communicate directly with the instructor. So I will keep you posted with any changes in the syllabus, which I don't anticipate. But please, 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 if you have an emergency, if you plan to not be on an exam day, communicate with me in advance. I need at least 48 hours of notification. Of course, there are emergencies that if there is an illness, just communicate with me as soon as possible. Other than that, have a great start, and looking forward to see you soon, week 4, 5. Okay, now I leave you in good hands here. Oh, if I manage, it's fine. Thank you.
We don't have a slide advancer. That's fine. It's so hard because I don't even see the slide. Okay, it's fine. It's a review session.
Yeah, so there's nothing required on this.
Yes, yeah. I was just as like helping out in this course, I was going to have an optional. Okay, so on Friday, there's no required class. I was going to host an optional review session for anyone that has additional questions or struggling and wants to like talk further about some content just from this week. And this week is going to be a really good time to just build those basics and get to know the material before going a little bit more advanced next week. So it'll be on Zoom. I'm going to send out a link to you guys and email everyone. But please don't feel like you have to. It's just a good opportunity. I'll go through some cases and some of Dr. O's cases and talk more about those. So if you want to, it's just going to be an hour on Zoom at noon on Friday. Not required again. Thank you.
Madeline, or very soon to be called Dr. Moss, is not just a P4. She's an exceptional P4. So you have an opportunity to take advantage of her and learn a lot about the P3 and P4. And I'm sure she can even talk to you about the residencies and organizations and everything. So she's an exceptional resource for you guys. It's up to you to use it or not to use it. In these next 2 weeks, we have a lot of optional process, and you're welcome to come. You're welcome to stay home. I highly recommend for you to come because we will prepare you for your exam. Because I know right now you don't care that much about the patient, you only care about your exam. So that's the way in the P2. But when we become P3 and P4, suddenly your focus change. You're trying to learn everything possible in a short time because you're focusing on the patient's care. So for now, please attend some of those reviews. She's exceptional, and she will basically tell you that how to study for not only for this year, actually for your P3s and P4s. So she's an exceptional resource for you guys. My name is Ali. Everybody call me Dr. O. You can call me anything you want to. That really does not affect me that much. And I look very mean and I look very different, but actually I'm a very nice person. But it is what it is. So I can't change my face or my attitude, but in general, I'm a pretty nice person. I like to start always with the case because everything we're gonna learn in this classroom has application to the patient's care. And we are going to start with the basic foundation, and we will go up and we'll learn, how to apply it. Now, I do have summary of all my lecture, 1 page, and I will do a lot of MCQ to the lectures, just to show you how to prepare you, how to study. For some of you guys love to memorize, this is not a very good class for you. You're going to fail. For people who like to understand, they actually don't even study. They just take the exam. They will show up. Portland, do you have any question? For people, for people who understand it, I tell you, you don't even have to study it. Because you do very well in the exam, and really there is not much to study because it's pretty straightforward material. I'm not the kind of person trying to trick you or anything like that. I just really want you to understand it. And the basic foundation of medicine is as important as clinical aspect. And so let's go ahead and start. I'd like to welcome everyone and to say, I don't care what is your nationality, what is your religion, what is your ethnicity, what is your sexual orientation. None of those affect me. What affect me is you become a competent pharmacist. And I'm in here to provide you with education. So it has to be bi-directional. It cannot be unidirectional. I stand up here and just do the talking. Feel free to raise your hand and ask question. And is it very obvious? I have a very heavy accent. If I'm not clear, just raise your hand and say, what the hell are you talking about? I'll be more than happy to explain it. And renal is not really a fun topic. Actually, it's a very boring topic. You're talking about PPP, that's all it is. So how to make it interesting is very difficult, but you really have to understand, the kidney and heart play extremely important in hemostasis. You're welcome to stop me and ask me a question. And if I feel you're taking too much of other people's time, no, I will tell you that. I said, hey, we can talk about it after the class. That's the reason we have so many review sessions, to make sure we're covering all the material you feel comfortable. So I expect you participate in this class. When you do your clinical rotation, everybody participate in the discussion. No one has monopoly on good ideas. We all work together to improve the patient's care. We are all going to work together to improve your basic foundation of the medicine and become a better pharmacist when you start practicing. Am I clear about that? And many, many times I stop and ask the same question. Am I clear? Please just raise your hand. Even if you don't want to say anything, just do it like this. Nobody will see you. I'll see you from here. And sometimes I tell you to wake up. I know as the heads are going already down, just because it's important. Some important concept I really emphasize and re-emphasize because it's important. And when it's important, you better believe it, it's going to be your exam. As simple as that. Because if I cannot tell you this is important, but when the minute I said this is important in exam, everybody start writing it down or put a star on it. It's like, yes, this is an important concept. Are we good so far? Any questions so far? Are we clear? Let's go and do it. Let's just start with the case. Who want to help me with this case? Thank you. I appreciate that, man.
Just read it.
Yeah, loud.
A 45-year-old patient comes to the emergency department because 5 days history of worsening swelling in his legs and numbness in his hands and feet. He first noticed the symptoms 5 years ago, and they have continued to gradually worsen.
So what we so far we know about this case?
Swelling,
That's definitely. What else?
a history of it.
History is
Longer.
chronic. It's chronic. This is not something acutely happened. It's something has happening for a long time. So this is, you need to pay attention, but it doesn't make it emergency. but you need to pay attention to it.
His temperature is 37 degrees Celsius, 98.7 degrees Fahrenheit. Blood pressure is 165 over 105 millimeters of mercury. Pulse is 60 pulses a minute. Respirations are 16 a minute. He has smoked 20 cigarettes daily for the past 20 years. A repeat blood pressure reading 5 minutes later shows a 170 over 105 millimeters of mercury.
Check it again. Well, most people are nervous when they come to the clinic. They come to ED, they'll come any place, they're usually nervous. So you want to calm them down, sit down, let's repeat it again, see if you're gonna get the same number or not. And this time actually it looked worse. It's 170 over 105. So now we're really paying attention, so something is wrong. We have a high blood pressure, we have this swelling in the head, and this is happening for a long time. And she has not received, he has not received any kind of attention. Thank you.
The patient appears to be alert and responsive to questioning. Physical examination shows 2+ pitting edema in his lower extremities and 1+ pitting edema in the upper extremities. Neurologic examination shows decreased sensation to touch in both hands and forearms and feet and ankles. Laboratory studies show.
But they did the lab, let's look at the lab.
Sodium 138 milli. Oh,
158, is it?
good.
Good, very good.
Potassium 4 milliequivalents per liter. Good. Chloride 100 milliequivalents per liter. Good. Bicarb 24 milliequivalents per liter. Good. Calcium 9 milligrams per deciliter. Creatinine 4.0 milligrams per deciliter. Not good.
Can be acute, but we just don't know, but the way the patient explained it, is that 5 years, that tells me most likely this is a chronic presentation, especially for the swelling getting worse. Excellent, go ahead.
Portland can't hear you when you don't have mic.
Oh, okay. This is one of us. Has to have a microphone. Please try it out. Thank you for letting me know. Okay, we'll go back and.
Urea nitrogen 50 milligrams per deciliter.
That's very high. Normal is around 10, so this is pretty high. And again, it's not a best marker of kidney disease, but it's not a bad marker either. So it gives me some clue something is wrong with the kidney.
Glucose 350.
That's terrible. This patient is terrible. This patient is type 2 diabetic, most likely. Has an insulin resistant. This is a classic presentation of somebody with diabetic nephropathy. Diabetic nephropathy is the leading cause of kidney disease in the United States. Diabetic nephropathy is the leading cause of the kidney disease in the United States. The second leading cause of kidney disease is hypertensive nephropathy. What was the blood pressure in this patient? Yeah, 170. So this patient has 1 and 2. 1 and 2. 1 plus 1 is? Wrong. Madeline, what is it? 1 plus 1? What is it? 1 plus 1 is 10. 10. I'm a math major. I know what I'm talking about. 1 plus 1 is 10. It's not additive, it's synergistic. Yes, when you have diabetes and you add the hypertension in there, it's not 2 anymore, it's 10. First leading cause is diabetes. Second leading cause is hypertensive nephropathy. When you add them up together, I can predict this patient will be on dialysis. If we don't intervene, less than 3 or 4 years. And dialysis is the end stage of kidney disease. When the kidney is not working anymore, and we have to basically dialyze them, artificially remove the toxin from the body. But this is a leading. There are 10% of the US population have diabetes. 10% of United States. That's the one we know diagnosed. There are a lot of pre-diabetic patients, and it's just a matter of time they present themselves. And when you have one opathy, you have all opathies. These patients have nephropathy and neuropathy, right? This patient have neuropathy. Are you okay with it? And the renal, look at the kidney, and most likely has retinopathy, most likely has cardiovascular disease, most likely has a lot of other complications related to diabetes. So it doesn't come an isolated situation. They come with pack number of the other different complications when they present it to you. So this is the most common condition you will see. And we will go through this patient until you feel comfortable. But in the beginning, we're going to talk about what will happen when you have those complications. Let's start with the second case. And who want to try the second? Thank you. No question, just kidding. You can go for it.
Were you just saying the cardiovascular disease? Did you know that, or was that based off of what was presented in the case?
When you have one opathy, you have all the opathies. When I see somebody have a neuropathy, I look at their eyes. In fact, their eyes is the first place it show up. And they have the retinopathy, nephropathy, and the neuropathy. I know they are at risk for cardiovascular. I will show it to you in a second, and you will see how bad it is compared to average populations. Okay, who want to read the second case? Okay, perfect. Thank you. But I have to stand close.
That's fine.
Okay.
All right.
Quick shower, don't worry.
Perfect. A 55-year-old patient comes to the emergency department because of a 2-day history of decreased urinary frequency. He was hospitalized for an episode of acute pyelonephritis 2 weeks ago and was treated empirically with ceftriaxone and gentamicin. His symptoms and laboratory abnormalities were completely resolved by day 5 of treatment, and he was discharged from the hospital 10 days ago. He says that since his discharge, he has been drinking lots of water, but has not yet urinated. He has no other medical history and does not take any medications. His temperature is 37 degrees Celsius or 98.7 degrees Fahrenheit. Blood pressure is 152 over 98 millimeters of mercury. Pulse is 60 beats per minute and respirations are 19 breaths per minute. Physical examination shows 3+ pitting edema in both lower extremities and basilar crackles in the lungs. Okay, gotcha. There is no flank pain or abdominal tenderness.
The pyelonephritis is gone.
A basal metabolic panel and complete blood count, urine analysis and glomerular, forgive me, that word is difficult. Glomerular, okay, I'm stopping. Filtration rate on his day of hospital discharge were within normal limits. Laboratory studies show, do you want me to go through?
Yes.
Okay, 100, sodium is 135 milliequivalents per liter.
Which is good.
Potassium, 6 milliequivalents per liter.
Little high or very high? I would say very high. Yeah, this patient have acute presentation. Previous patient was chronic, but this one is acute. Look at it, it's 2 days ago. That's a very different scenario. And potassium 6 for someone who never had a potassium issue is pretty big. And what is the sign and symptom or consequence of high potassium? What's the sign and symptom? Okay. Usually it's pretty benign. What is the consequence? Sudden death syndrome. Are you following me? Yeah, if you're lucky, they will have some symptoms, but a lot of them is sudden death syndrome. They can just pass out and die from the cardiac arrest related to the high potassium. Actually, it's considered medical emergency. Hyperkalemia considered medical emergency. So it's something that you stop everything. The last patient I said, wow, okay, has been happening for 5 years. In here, you stop. You take a pause and take care of the patients right away because this patient's potassium is 6. And we will talk about it, not this year, next year, how to manage it. But this is more emergency right now, and you have to treat it. And this patient never had any other medical condition. And when you look at the lab, and especially you look at the creatinine, the same number 5, BUN is 60, and the FeNO is 3%, but we'll talk about that later on. Hematocrit is 25, hemoglobin is low, and the platelet is low. This patient actually had aminoglycoside nephrotoxicity. This patient received gentamicin, and you should know gentamicin is nephrotoxic. Gentamicin is a nephrotoxic medication. This patient has acute kidney injury related to gentamicin. And as a pharmacist, you should really recognize any drug that has potential for nephrotoxicity. But aminoglycoside are classic class of drug that they can cause nephrotoxicity, as this patient is presenting in here. So we have 2 patients with complete different presentations. One was more chronic presentation, one was acute. One is called acute kidney injury, one is called chronic kidney disease. The etiology was different and presentation was different. And hopefully by end of next 2 weeks, you feel comfortable with acute kidney injury and chronic kidney injuries. Any questions so far about these 2 cases? Am I clear? Are you guys up or sleepy? Yes. They tolerate it better because they have it for a long time. We're saying somebody who had never had a high potassium, that high potassium can put them at risk for cardiac event. They learn to tolerate it. Myocardium really tolerate a higher potassium when it's a chronic kidney. Make no mistake, it still is a medical emergency. It still is a medical emergency. Doesn't matter if it's acute or chronic, it's a medical emergency. And you have to jump in and fix the potassium as soon as possible on that individual patient. Yes.
So that is above 5 milliequivalents per liter, then it should be
6 is the one. 5.7, 5.8, above 6, I consider you do the EKG right away, and after that, you have to treat them to make sure that it's true high potassium. And EKG will show you, as you see a big T wave on the EKG, and you know for sure this is a hyperkalemia. When you look at the incidence of the chronic kidney disease, minorities are disproportionately higher at risk for chronic kidney disease. And there are many reasons, discriminations, lack of the healthcare. You look at doesn't matter related to the income and everything, every minorities, Native American, Black Americans, Asians American, every single minority is much higher risk for developing chronic kidney disease. And because the way our system is designed in the United States, we like it or not, is the healthcare is for the rich. It's not for average person. And the people who are on the bottom are the one that they're really suffering from all the crises related to chronic kidney disease. We see very high incidence of hypertension. We see a lot of diabetes. We see a lot of comorbidities among the minorities. The take-home message is, please take your time. Take your time. You as a pharmacist, you have a very close contact and you are very inexpensive compared to the doctors or NPs or PAs. Make sure you do your job right and provide excellent care for those individual patients. They don't have to pay you $400 to visit you. If they are taking blood pressure medicine, be aggressive. If they have diabetes and hypertension, be 10 times more aggressive. So really it's so important to pay attention. And when you look at this, now, what is the significance of this? The significance is this. Are you following me? Are you guys looking at the graph? I want you to look at somebody is 25 to 34. Are you following that number? If you are, by the way, this is log parameter. It's not like a 1, 2, 3, 0.01, 0.1, 1 point is go up. So it's log sheet. If you are 25 or 34 and you have chronic kidney disease, are you following me? Look at the graph. You are greater risk for cardiovascular event than somebody who has no chronic kidney disease and is 75 years old. Do you see the graph? If you are 25 years old, you have greater risk of cardiovascular event than somebody who is 75 or 85 years old and they don't have chronic kidney disease. So that's the reason we care. Because a lot of these patients die at very young age. With no exaggeration, when somebody develops chronic kidney disease, the life expectancy go down as much as 60 to 75%. Even you transplant them and give them a kidney, it go down by 20 to 25%. So the best thing to avoid this patient end up on dialysis is to manage their disease process as fast as possible to make sure they don't end up on dialysis. Back to your point, how do I know? This is telling me when you are that bad at kidney function, you're very high risk for cardiovascular event. And most of them, 75% of them die from sudden death syndrome because of a lot of electrolyte abnormalities. And back to our second patient, by the potassium of 6. We'll be very concerned about the deaths related to hyperkalemias. Why AKI, acute kidney injury, and CKD matter? I just showed it to you. Major risk factor for mortality and morbidities. Major risk factors. Even they recover. We even transplant them. It's still they're higher risk than average person when it's come to the long-term longevities and quality of life. If they get them in a hospital, acute kidney injury, they end up in the hospital longer. The study have shown even in the hospital, they recover around 10 to 15% of them end up on dialysis long-term. And has anybody working dialysis unit seen a patient on dialysis in this room? Nobody? Have you had any experience with those? Have you talked to those patients? No. You know, you sit in the machine for 4 hours and you do them 3 to 4 times a week. The blood leave your body at 400 ml per minute. 400 ml per minute. You're filtering the whole blood in over 5 to 10 minutes completely. And when you walk out of that machine, you are exhausted. You can't even hardly walk. Sometimes the blood pressure of 170 dropped to 90s. Just to show you that how exhausting dialysis is on these individual patients. And now we are reaching around 700,000 people on dialysis in the United States, and just continue to get bigger and bigger as the time has passed. Let's go back in physiology and anatomy. You should feel comfortable with the kidney anatomy, because we will talk about it through the lectures, and you should know where exactly we are talking about. Most of us have 2 kidneys. Why do I say most of us? Some of us are born with 1 kidney. Some of us have 1 kidney and a half. Some of us have very small kidneys that both of them together work as one. Some of us have donated kidney. Most of the kidney get around 25% of cardiac output. That's a lot. Kidney is a very interesting organ. It's the size of your fist. 25% of your cardiac output go through here. 20. It's the most selfish organ when it's come to oxygen saturation. It's just me. It's like a little babies. You know, the babies don't cry. They always say me. That's all they're saying. And same as kidney. It's a selfish. But guess what? It's the most giving organ. The minute something go wrong in the body, is the first one shut down completely and said, take care of everybody else. If the heart is something happen, take care of that. If you have sepsis, take care of that. If you have a liver disease, take care of that. It's the first organ always give up. They said, let's take care of the stroke. Let's take care of the brain. Let's take care of the heart, the liver, a small intestine. Let's take care of those. Don't worry about me. But when everything is fine, it's the highest oxygen saturations. In general, most of us have renal artery and we have renal vein. One is bringing the blood to the kidney, and other one is taking it back to the circulations. And 25%, as I said, come through those. The cortex, there is a capsule, and after that is a cortex. And cortex has 80 to 90% of the blood supply. And I will show you in a second. When you think about the kidney, think about it like a capillary bed. It's all blood. Literally, it's all blood, because every part of it is getting so much of that cardiac output. And you have the pyramid, and after that, you have the area of the urinary production. We call them ultrafiltrate. You call them pee, somebody else call them urine. You get that yellow color. In fact, it's supposed to be clear. It's supposed to be clear. The reason is yellow because of bilirubin. But if you're dehydrated, of course, it will become brownish. But in general, those people who are well hydrated, and I don't see any water bottle around here. Oh, I see one back there. The people who are well hydrated, they tell you, my pee is always clear, which is a normal. That's a normal color for the urine. Maybe just a light of the yellowness, but it should be literally clear for somebody who is well hydrated. And it drains through the ureters to the bladders and eventually leave the body. All of you guys are sitting here, 25% of the cardiac output. That would be how many liters of the fluids go to the kidney in 24 hours. What's your cardiac output? What's your stroke volume? The cardiac output is around 4 to 5. Okay, 200 to 250 liters. Are you following me? 250 liters of blood go to the kidney. 250 liters. How much urine do you make every day? None of you guys measure that? Well, most of you guys make around 2 liters of urine. Maybe 1.5 to 2 liters of the urine. Can you imagine what a filtration pathway it has to be? How efficient it has to be? Can you imagine how much of your weight, less than, if there was no efficiency in the system, you will be dehydrated matter of minutes to the point that you collapse. You will collapse. It's an incredible filtration system that can reabsorb all this volume and put them back in the circulations. But at the same time, it's filtering out all the toxins and all the excessive substance or compound that, or xenobiotic or anything that your body have been exposed to through the days. So it's an incredible system when you think about it, how it functions. You better know the anatomy, right? You gotta know the anatomy. So I put this one up there. When you get home, memorize the anatomy, and after that, go on this. You should be able to draw every single one of them, where each of those are located, and to make sure you know those areas. Now, if you look at the big magnified kidney, you have the renal artery, you have segmental arteries. Those are the ones that just start going to each of those pyramid. And you have, of course, the renal vein is the draining systems. But the cortex, you see those cortex? That's the biggest part that has the highest amount of the circulations. And you have so many nephron. One more time. You have so many nephron. Most of us are sitting in this room. We have around 1 million nephron. 1 million nephrons. Just to show you, if somebody asks you how many % of your kidney function do you use, most likely around 40 to 50%. That's the reason you can donate a kidney and live without any complications, because you really don't need all those. It has to be significant injury to the kidney before it starts showing as a disease, because you can compensate. You're using only 40% of it. You go to 50%, you go to 60%, you go to 70%, but eventually there are so much damage to it that cannot compensate anymore. And that's the time that this patient have sign and symptom of the disease. But the cortex is extremely important because of the amount of the blood supply that you have in this area. And draining system is very important. Draining is important because we all have to get rid of the ultrafiltrate or the urine. Now, most men, as they get older, it's a God discrimination against a man over 65 years old, their prostate get bigger. When the prostate get bigger, the draining system start clogging up. So when they cannot drain, they just having reflex kidney injuries, because the urine has to go, instead of going down, it will go up. And urine is supposed to drain out through the bladder. Now it's going to be packed. So it's not going to drain anymore. And as a result of that, you will see the increased amount of the reflux nephropathy. Why do I tell you all this stuff? Well, because you can have 3 kinds of kidney disease. You can call them pre-renal. It's what the supply is, the supply. Another one is a kidney disease. We call them renal. And the last one, we call them post-renal kidney disease. It's the kidney by itself is working. The drain system doesn't work. You can literally say for every disease, doesn't matter it's a cardiac, doesn't matter it's a liver, doesn't matter it's pulmonary, all the major organ, you have 3 separate presentation. Is before coming to the organ by itself, or outside of the organ. We call them pre-renal, we call them renal, we call them post-renal. Those are big 3 categories of the kidney diseases. Second patient, even the first patient, are renal diseases. But there are a lot of people who have heart failure or they have liver failure, they develop kidney disease because they have problem or infection, sepsis. They can decrease the perfusion to the kidneys. And an old gentleman can have prostate issues, prostate cancer, or just hypertrophy. You get older, it just gets bigger and bigger. And you will have problem with draining of the urine, and they can come with the chronic kidney presentation. Now, we do have different drugs we can use to relax it, or we can do surgery. We can go just, take some piece of it out and make it open so they can, drain it. So we do have a different way to manage each individual patient based off of it. But prostate uropathy is very common, especially in older men that they have. So I just want to give you a few examples how you should prepare for your exam. Most of the questions in exams are case-based. Most of the questions, I never ask you to memorize fact, is most of the questions are case-based. You have a 65 years old patient, go to his primary care physician because of trouble initiating the urination, a problem that has slowly progressed over the last 6 months. A digital rectal examination revealed a uniform large rubbery mass. So it's large. It is large, but why it is smooth? Because if it's not smooth, you're worried about the prostate cancer. So it's smooth, so you know for sure this is just enlarged, and 65 years old. So yes, that's the time you should expect to see that. And most of them tell you, you know, I go in, I can't empty my bladder. I just say, most of you guys young, you don't understand what I'm talking about. You know, when I go to bathroom with some of these young people, they just, I can hear it all the way from bathroom. People my age, we go, drip, drip, because it's just the flow is not there. Just the flow is not there for older men because of the prostate. These patient urinary problem are likely through which of those processes? Compression of the bladder. You know, bladder actually is very amazing muscle. You can train the bladder. You can really train him to expand it. A lot of older women, when they have neurogenic bladder, they learn how to train it. So it's very effective. Compression of external urethral sphincter, you know. Compression of membranous urethral, we didn't even talk about that. Compression of the penile urethral, we didn't talk about that. Compression of prostatic urethra. That's the most common cause of the prostate hypertrophy. There's prostate get bigger and it put the pressure in there. This is what I was telling you. When you think about the kidney, think about the capillary bed. What is capillary bed? There is no structural. I know it has a structure. I know the nephron. I know glomerular filter. I know the tubular. But just to show you how much blood go to the kidney, think about it more like a massive amount of the blood is going. 25% of the cardiac output. That's incredible. The rest of the body, your heart gets 5%. 5%. Even during the exercise, of course, heart's going to get a little more, but what the kidney does, sometimes it decreases it. That's the reason when you exercise for a long time, when you go to pee, what color is it? Dark. And can you pee? Not really. It really decreases. At that time, yes, that's a different story. But in general speaking, that's what you think about the kidney. And big capillary bed, that all these bloods are going in there, and it has to be filtered. It has to be filtered. It's a very efficient system that you have. Look at the difference on cardiac output. Kidney get 20 to 25% of the cardiac output. All your muscle together, 15%. This is the size of the kidney. Look at all the muscle you have. Yeah, that's the difference. That's a 5%. This one is 25%. And look at the heart, myocardium, around 5%. So sensitive to, but when there is an injury, that's the first organ always give up. Because that figure out that, you know, right now I have to provide fluid and blood to the other organ. Those are more essential than myself. It's a very giving organ, at the same time, very selfish organ that you have. Which of the following tissue received the highest percentage of cardiac output at rest? You should know the answer, right? Now, if I would have said, what is, I can ask the same question as it, which of the following organ has the highest oxygen saturation at exercise? What would you say? Myocardium, heart. Heart will have the highest. But in general speaking, the kidney at rest is the highest concentrations. So now let's break it down to the molecular level. As I said, you have nephron. That's a unit of the kidney that does all the work. By the way, what time is it? 46. Okay, let's take a 10-minute break. We come back. And I said 10 minutes, not 10 minutes, which is like a 20 minutes. So come back in just a 10 minutes. Portland, can you hear me okay? Hear me okay, Portland? Oh, there's a clock up there. There's a clock up there. That's good. Okay. Let's go ahead and start. Is Portland folks can hear us? Is Portland can hear us? Oh, I don't know. You will be surprised. This is not my first rodeo. Did they text you? Where is our officer? The guy, our officer is falling asleep. Can they hear us? Oh, good. They can say something, by the way. It's not a mortal sin. Okay. So now let's look at the nephron. Now, this is very important. This is very important. I really want you to feel comfortable, because that's when we talk about diuretic, you have to know exactly where all these nephrons work. We have loop diuretic. That would be your furosemide or torsemide. We have thiazide diuretic, and that would be your hydrochlorothiazide. That would be your cortalidone. And we have mineralocorticoid receptor antagonist. That would be your phenylalanine, spirolactone. So you have mannitol, you have acetazolamide, you have so many different forms of diuretic, and they work at different part of the kidney. Now, when you look at it, the cardiac output, the amount is going in there, it has to be filtered. So you have glomerular membranes, its function is like a filter. And literally it has 3, you can argue 4 separate layers, definitely 3, and you can talk about even the 4th one. You have 4 layers. Why that's important? You know, if I see red blood cells, if I see the urine is red, I know something is wrong. When I see the urine is foamy, I know something is wrong, because I told you already, the urine has to be clear like a water. It means that glomerular membranes are not working anymore. There is an injury to them. It cannot filter anymore. Everything is passing through. And we don't want that. So that would be your goal. Another thing about the glomerular membranes is very interesting. It doesn't like changes. It likes to be constant. I'm standing here, my blood pressure go up and down. Did I say something wrong? Did I piss off somebody off or something like that? I do them all the time. Don't worry about that. And you're sitting over there. Oh man, I am so tired. I just want to go home and rest. Your blood pressure is low. My blood pressure is high. But guess what? Both of us have the same pressure in our kidney. Kidney can regulate. The glomerular membranes can regulate. Does not like this high and low pressure. Is as much as possible, it try to stay constant. And with so many hormones, it keep that pressure at all time constant. Same as your brain. These 2 organs, they don't like fluctuations. They like a constant normal. When it go above, they don't know what to do. They act completely different when it's above or below. When it's below, it shut down itself. When it's up, it starts blowing up the blood vessels. So it really like to keep it constant, regardless of what is my blood pressure, go up and down through the day. And nobody sitting in this room, remember our first patient, we checked the blood pressure and 5 minutes later on was different. Nobody in this room have a constant blood pressure. Your blood pressure go up and down. When you go to sleep, blood pressure go to sleep. It's called dipping, all of you. By 20 to 30 millimeters go down. When you're exercising, of course, it go up. When before the exam, it way, way up. When you get your result, a skyrocket high. So that's reality. But guess what? Through all this process, the GFR, the perfusion to the kidney, stay constant. And how does it do it? With a lot of hormones. After it filtered, it keep it constant. It has to, that's a lot of volume is going to the kidney. It has to reabsorb everything. You have the proximal tubes. The proximal tube, almost 75% of everything is go to the kidney, it gets reabsorbed in the proximal tubes. A lot of water, a lot of sodium, and always remember, water follows sodium, sodium follow water. And everything that sodium follow, usually the chloride follow. The water follows sodium, sodium follow water. That's a normal human physiology. So if I can reabsorb sodium, what am I going to reabsorb? Water. In fact, all the tubulars are based of sodium channels. With the reabsorption of the sodium, I can reabsorb all the water. 75% of the sodium will reabsorb on the proximal area. And in fact, a lot of glucose get absorbed. If there is a little bit of protein in there, it gets reabsorbed. A lot of part of that filtration that escaped and will not filter, get reabsorbed. And when I say reabsorb, it just come back to the circulations. There is still 20% left until it hit the loop of Henle, the ascending loop of Henle. When it's moving up, it absorbs another 20% of the sodium. With absorbing 20%, you absorb another 20% of the volume. And by the time it gets to the distal tubular, it absorbs another 4% of the sodium. Another 4% of the sodium. Now in here, you reabsorb another 4%. And when it gets to the collecting duct or collecting pathways, 1% left. You're trying to absorb that. So you end up losing out of that 250 liter of the fluid has gone to the kidney, you end up losing around 1 liter to 1.5 liter through the urine. Now, of course, all of us are different sizes. I usually say 1 ml per kilogram per hour. 1 ml per kilogram. Somebody who is 50 kilo, they lose around 50 cc times 24, 1200 cc of the fluid a day. Somebody who is overweight, which is not very good because the kidney has to work so much harder. They call them hyperfiltrations. Hyperfiltration. In fact, obesity and the weight is a major risk factor for kidney disease because those kidneys have to work so much harder to get theirs, get the fluids to reabsorb. And so those are the general. Now we do have loop diuretic. We don't have any drug that work in the proximal tube. You know why? If I can give a drug that inhibit the sodium channel and the proximal, those patients will be dehydrated in a matter of minutes and they will collapse. So I'm glad we don't have any drugs that affect the proximal tube. What we have is loop diuretic. They work in ascending loop of Henle, ascending loop of Henle. Let me show it to you on the, so the people in Portland can see it. Ascending, this is the ascending loop of Henle. That's the area that your loop diuretic work. And we're going to talk about those in next few days. You have thiazide diuretic. They work in the distal tubulars. Mostly beneficial for treatment of hypertension. And the last group of drug, we call them MRA or mineralocorticoid receptor antagonists. They work in the collecting duct. They're not a very good diuretic, but man, they're so good for the heart and they're so good for the kidney. And I explain it in a second why there's such a nice effect from those medications. Just one more time. You have afferent arterioles, it brings the blood to the kidney. Efferent arterioles take the blood out of the kidney. At any time you're sitting here, only 10% get filtered. One more time, only 10%. Most of them come from 1 and they go through the other pathways. Why? Because the GFR has to stay constant. It has to stay constant. There's no reason to increase the pressure. So with 10% get filtered, and that's plenty of filtration because you're doing it 24 hours a day, every minute, every second. That's excellent. So 10% at all time. So afferent, bring it in, efferent, leave it. But kidney is so smart. When it feels the pressure change, when it sees so much of sodium is coming, when they see the blood pressure is going up, it causes afferent and efferent arterioles, vasoconstriction, vasodilation to keep that GFR constant. The body can knows when to close, when to open. Sometimes both sides, sometimes both side dilation, sometimes one side dilation, sometimes the other one. It's amazing how it figured it out every second how to work. You have these jacoglomerular cells, they're like a sensor. They can sense the pressure, but more important, they can sense sodium. Those cells can feel the sodium, how much sodium is coming to the kidney. If there is a lot of pressure, if there's a lot of circulation, a lot of perfusion to the kidney, the concentration of sodium will be higher in the kidney. It can feel it, okay, that's too much. I got to decrease the pressure. I can cause a vasoconstriction for what it comes, or I can cause vasodilation as it goes. It's pretty smart to know how to manage every part of it. We have glomerular membranes, and that's a filtration area, and I'll show you in a second. And you have this podocyte. They are epithelium cells. They're one part of the outside of the glomerular membranes that really act as another set of filter. So you have those podocytes, you have the food processes. That's the reason I said 3 to 4 layer. You add the podocyte, that make it a 4 separate layer that you have how to. And even that, is still some stuff will leak out. It go to the proximal tube, and in the proximal tube, you will reabsorb majority of the what is gone. So if I want to break it down, kidney has 4 major functions when it's come to the glomerular filtrations. One is the filtration process. You bring everything to the kidney in order to filter it. Are we good about that? Am I clear about that? Don't worry, if you don't understand, let me know. I will explain it. Are we good about filtration process? It's like you have a filter, make sure the toxins go, all the good stuff, white blood cell, platelet, red blood cells, protein, everything is stay back. That's called filtrations. The second part is reabsorption. Wow, that's a lot of fluids going to the kidney. I got to get everything back. On the proximal tube, in the distal tube, in the loop of Henle, in collective duct, I got to reabsorb. The reabsorption is based off sodium channels, chloride channels, sodium to chloride channels. But water always follows the sodium. When you reabsorb those sodium, water will reabsorb with those sodium. And sometimes toxins or some stuff going through or need to be secreted. Basically what you do, you take him from the blood supply and you take him and dump him in the urine. That's an active process. A lot of drugs actually get secreted in the kidney or a metabolite secreted in the kidney. You end of the day, you got to get rid of the drugs. End of the day, you got to get rid of the drugs. That's the reason you take them every day. It's the metabolite or the active. You got to get rid of them. A lot of them get secreted in the tubulars, so you lose them. And the last thing is excretion. Basically, you pee them off. So you can argue with me that the filtrations and the reabsorptions and the secretion of one process, excretion is one process. Yeah, you can do that, but it's a different step process. So it depends what textbook you read, they have a different definition for it. But end of the day, xenobiotic, many drugs, anything that is not supposed to be here has to be eliminated. If it doesn't, it's going to accumulate, very soon will be toxic. So in pharmacokinetic, you will learn, or you have already learned, how to adjust the dosage based on kidney function. Why do we do that? Well, because of this. If I don't adjust the dosage, a patient who have a chronic kidney disease need only 20% of the medicine compared to somebody who has a normal kidney functions. And old people, I don't have a skin disease. Actually, I do, but I have a lot of wrinkle. Wrinkle does not make it a skin disease. That's an age process. And that's true for the kidney. By age of 30, your GFR start to reduce around 1 ml to 2 ml per year. By you reach my age, you have lost 30%, 40%. And when by the time you get 80, you have lost 80%. Why older patients are more susceptible to side effect of the medication? Because we don't consider reduced renal function. If you consider reduced renal function, they should not see more side effect from the medication. We don't adjust it accordingly based off their age, and you end up with more toxicity from the drugs. If I want to summarize the function of the kidney, of course, the filtration is the most important one. But the one that really visual is high blood pressure. The blood pressure controlled by the kidney through release of all the different hormones. They control the adrenaline gland, so epinephrine, norepinephrine. They control the autocoid, that would be leukotriene, that would be prostaglandin. They affect the cytokines, they affect the hormones, the angiotensin, adenosine. There's so many hormones comes from the kidneys, it controls it. I put the acid base, you don't responsible for now, but next year you have to know about acid base. They really play important role in acid base regulations, especially metabolic. The respiratory, that's pulmonary condition, but metabolic acidosis, really kidney control it. Most patients have a chronic kidney disease, they're acidotic. As a result, they're always breathing harder. They're trying to get rid of some of the acid. And they play such an important role for hormones. The vitamin D, most of the patients who have chronic kidney disease, they develop osteomalacia because they cannot convert the vitamin D to the active vitamin D, and they cannot build up the bones to develop osteomalacia. And of course, they develop osteoporosis, but they don't respond to the bisphosphonate. They do not respond to bisphosphonate. They make erythropoietin, EPO, or erythrocyte stimulating agent. We use a lot of erythropoietin in dialysis patients to increase the red blood cells. Go back and look at those cases. The patient have very low hematocrit and hemoglobin because you need erythropoietin to produce and release to increase the progenitor cells to make the red blood cells. Patient with chronic kidney disease, a lot of them are anemic. If you look at them, you say, man, this person is so pale because they just don't have the red blood cells. They don't make that erythropoietin. So you have to give them artificially twice a day, twice a week, 3 times a week. You have to give them the erythropoietin to increase the production of the red blood cells. And sometimes they become resistant. They don't even respond to erythropoietin. You have to give them a lot of blood and blood product. And unfortunately, those patients become brown. They develop iron toxicity. They develop iron toxicities. And those irons going to go sit in their heart. And what's going to happen? They develop cardiomyopathy. It's a metal. Iron is a metal. When you sit and deposit in the heart, it cannot function anymore. It's become like this. Your heart is like this. It's pumping. Their heart is like this. It cannot pump anymore. No wonder you're 18 years old with the chronic kidney disease, you're at the same risk of cardiovascular disease as somebody who is 85 years old. It affects every part, the kidney affects every part of the body. And as a result of that, it comes with the high morbidity and mortalities. So, few important points. The filtration happens in the glomerular areas and mostly through the sodium channels. And sodium and water, they're always coexist. The water goes, it's so funny. Every species in the world control the volume through these sodium channels. There is not even one. And it goes back to the evolution. Now, don't write a nasty note about my evaluation. It's a science. I'm not trying to tell you anything different. We all came from water. Water is the origin. That's the controlling the sodium and water is so important. Every species has that. Through the aldosterone, every species has the same hormones to control the external and internal through the volume, because water follows sodium, sodium follows water, and it keeps the hemostasis completely constant. We have sodium 65% reabsorbed in the proximal areas, and of course, some other solute. Loop of Henle, 20% reabsorbed, and some of the sodium again in there. And the distal, as I said, 5%, and collective 1 to 2%. If for some reason there is injuries and you have significant amount, there will be more 4 to 5%. But in general, very low number of these electrolytes. But look at the amount of the glucose, look at the sodium, look at the amino acid, look at the protein, look at everything gets reabsorbed in the proximal area. By the time it reaches to the urine, you have a little bit of creatinine, you have water, and you have urea. What did I tell you in the beginning of the lecture? It has to be clear, because it all have been reabsorbed through the whole process. If it doesn't reabsorb, something is wrong. It's been the patient have some sort of the kidney disease, is not doing his job correctly. What is the term to use to describe substance moving from peritubular capillary into the renal tubulars? What do you call that? Reabsorption? No. Excretion? No. Filtration? No. Secretion? Yes, there was 3 of them was no. So the last one has to be correct, right? Holy cow. Are you guys awake? Who is asleep? That was a hard question? Really? Okay, one more. Which of the following component of the nephron perform the functioning filtration? Which of the following part of the nephron function the filtration? Let's start with the B. Proximal convoluted tube, that's reabsorption. Medulla, that's the part of the, it's not part of the nephron. Thin ascending lip of the Henle, no, that's reabsorption. 10 descending limb, no. So what's the correct answer? Glomerular, that's the unit of the nephron that does all the filtrations. Okay, let's look at the glomerular filtrations. So the efferent comes in, and efferent will take it out. When it come in, you have this glomerular membranes in here. This is efferent. Do you see this? This is efferent, and this is efferent. It's coming from here. 10%, 15% is going here. 85 to 90% is going there. And that 10 or 15% get filtered. But you're doing it all day, 24 hours a day when you're asleep. It's part of autonomic nervous system. Autonomic nervous system. It's not part of your somatic nervous system. It's not part of your, it's automatically it's happening, all this. So it's coming through. So if I look at it, if I open the glomerular membranes, that's what you see in here. It's an electron microscopy. You open it up, and you will see the differences in the membranes. So if I take it that piece and I blow it up, you will see 3 separate layers. You see the endothelium membranes. That's the first layer that you will see. The first area that you're seeing is endothelium membranes. You have the food processes, and you have the podocyte, and you have the glomerular membranes in here. So you have 3 separate membranes. You have the blood is coming through here. You have the endothelium membranes. You have the glomerular membranes, and you have the food processes. And once in a while, you have a big podocyte in here. That's another form of the epitheliums. So when it's coming in here, that's the pressure. It's coming in here, but it has to keep it constant in here. Am I clear about that so far? Any question? So now it has to be a small to go through here. If it's the red blood cell, what's going to happen? Filter cannot go through. White blood cell cannot go through. Albumin is very interesting. If you look at the charges, it's negative. Albumin in your blood, which holding it, is negative. Negative to negative charge, separate, so it should not go through. When you see the urine is foamy, people say, I am peeing shampoo. Literally, they tell you, I'm peeing shampoo. When I go to the bathroom, it's just like foam everywhere. You know, it's have a lot of albumin in there. When people say, I'm peeing Coca-Cola, I know that's the red blood cells. And they said, I'm just peeing Coca-Cola, it's dark. I know for sure there is a damage to here, and these red blood cells are passing through. So that's the way we know that where is the site of the injury is to the kidney based off the patient's presentations. But look at here, how efficient it is. Even there is a small damage to here, you have the glomerular membranes. And this is finasteride. Like a small, nothing can go through, big molecules cannot go through. It's the smallest hole you can imagine. Look at the graph. Nothing can go through this. The bottom graph, not the top graph. Look at the bottom graph. Look at it, it's like exactly like a membrane, but actually that's a filter. That's a filter. Look at it this way. You have the epithelium, that's the food processes. You have glomerular membranes, basal membranes, and you have the endothelium cells. And the red area is the blood. It's coming from the afferent arterioles, it's coming to the glomerular membranes and get filtered, and the fluid it will leave in there. It's all these holes are in here. You have all this little area that is just passing through. It has to be significant injury to the whole thing before you can have a lot of injuries to the kidney. This is exactly the same thing. You have endothelium, that's your endothelium. You have the second one, basal membranes, that's glomerular basal membranes. The last one is podocyte and food processes, those are epithelium membranes. So 3 major or 4 major different filtrating pathways that make sure that 250 liter of blood is going to there, stay in the circulation. Even 1% leak out, that's a lot. And when the albumin leak out, like our first patient, albumin start leaking out, what's going to happen? Your albumin levels go down. When albumins go down, the fluid is going to go from intravascular to interstitial. And all these patients become so swollen. You look at their eyes, under the eyes is just so puffy. The legs are this big. They tell you, I cannot put my shoes on anymore. And sometimes it gets so big, they start leaking from their leg. Literally, we have to wrap it that they can get dehydrated. You have to wrap it so hard to keep him. That's the reason it's so important to keep everything in there as long as it's possible. A patient come to the physician with 3 weeks history of fruity urine. What would be fruity? Sugar. As well as edema. Why this patient have edema? Most likely, I'm leaking albumin. He has history of chronic hepatitis B. A urine dipstick is positive for protein. There should be, what should be in the urine? Nothing. It should be water and maybe a little bit urea, but no protein. Protein should not be in the urine. So when you see the protein in the urine, something is wrong with it. Show 4 grams of protein per day. That's terrible. In fact, we measure it based on milligram, 30 milligram. When it's more than 30 milligram, we get concerned. This patient has, look at the difference. It's huge. 4 grams. Sometimes I see patient with 12 grams. 12 grams. And I can tell you, those kidneys are fried. So a renal biopsy showed subepithelium deposit with a spike and dome appearances. The positive urine dipstick for protein is most likely to damage what part of the glomerular. So think about it. Biopsy demonstrated subepithelium. What is subepithelium? This is epithelium. What would be subepithelium? Glomerular membranes. This is epithelium. That would be subepithelium. The positive urine dipstick for protein is most likely to damage which part of it? Bowman capsule, that's the outside. Capillary endothelium, that's way up in here. Glomerular basal membranes. That's the correct answer. That's the correct answer. That's the reason you cannot memorize my questions. You gotta understand it. Because in real life, they are not going to tell you when you're reading the biopsy, you have to know where the injury is. Nobody is going to stand up and explain to you the biopsy. Everything is electronic. You have to read the biopsy. You look at the lab, you read it. You have to know what is sodium, what is potassium. It's the same concept. So you know exactly where the damage is done to this kidney. So you look at the urine, 200 liter, 300 liter goes through the kidney, depending on what day it is. By the way, when we say water is different than the blood, because what blood has what else in there? A lot of cells. The amount of the blood is different amount of water because you have so much cells in there. So it's going through the kidney. How much urine do you make? 1 or 2 liters. What do we have in there? A little bit of sodium, a little bit of potassium, and everything 94 to 96% is just pure water. But any kind of cellular or any kind of protein should not be inside the urine. In fact, I argue you should not even have glucose in there. You shouldn't have anything in there. Now, if somebody's blood sugar is, like our first patient was above 350, yes, it is going to start spelling in the kidney. For most of us, we will reabsorb it immediately in the proximal areas. And the more glucose showed up on tubular, the more injury you will have. Because it's not supposed to be there. Those are all the foreign compounds that are not supposed to be in the tubular areas. So you look at them, you have to have water, that's the majority of them, a little bit of uric acid, a little bit of creatinine, but really everything else should be completely, no red blood cells, none of those should be in there. In general speaking, no protein should be there. The final component of urine do not include glucose, that's correct. Urate, very small. Creatinine, very small. Should I have a lipoprotein in there? Absolutely not. Absolutely not. Should I see any protein in there? Absolutely not. None of those should be in the urine. If there is, something is wrong. That's one of the first tests we do. We check a serum creatinine. After that, we check the BUN. The next thing we always check in the urine is the proteins. It tells me exactly what's going on. Of course, the history of the patients. Those are the main parameters that we always look at them to make sure where is the site of the injury to the kidney. All of us function very well as long as we keep the mean arterial blood pressure over 65s. And our body try as much as possible to keep this mean arterial blood pressure. As I said, it go up and down, but it does not allow it to go too low. The minute it gets less than 65, that's the time that you're compromising the kidney function. So how the kidney does that is the key base of all the cytokines and autocoid and all the hormones that the kidney release. You have nitric oxide cause vasodilation. You have prostaglandin cause vasodilations. You know, as a pharmacist, one thing I want you to remember, what is the worst class of drug for the kidney? NSAIDs. Now you know why. Now you know the rest of the story. Because you're interfering with the prostaglandin. And the prostaglandin really control the perfusion to the kidney. Now, young people like you mostly run based off epinephrine, norepinephrine, and angiotensin, but old people drive them based off prostaglandin. You give these old people the NSAID, is a whole different ballgame. Easily you can develop acute kidney injury from the NSAIDs. Beside the cardiac and hypertensions and GI bleed and everything else that they can cause because of effect on the prostaglandin. Endothelium and leukotrienes, those are vasoconstrictors. In fact, endothelium is the most potent vasoconstrictor we have in our body. Angiotensin 1 and angiotensin 2, vasoconstrictions. Vasoconstrictions. ANP, atrial natriuretic peptide, actually they're vasodilators. They work against the angiotensin. They work against the angiotensin. That's very important when you learn about cardiac diseases. Because when you have a cardiac disease, your angiotensin levels go up. Why? Because you're not perfusing to the kidney. When you're not perfusing to the kidney, what is the kidneys respond to? Release angiotensin to cause vasoconstriction. But that angiotensin is so harmful to the heart, and you will learn ACE inhibitor are the drug of the choice for majority of people who have a heart disease, because they do exactly opposite what angiotensin does, inhibit the production of the angiotensins. Epinephrine and norepinephrine, they cause vasoconstriction. Again, it's so important for the heart. You will learn people have a heart failure or they have high blood pressure. What drug do you use? Beta blocker. Adrenergic receptor antagonists, beta blockers. Dopamine at low doses increase the perfusion, at higher doses cause more act as like epinephrine and norepinephrine. But the body releases dopamine in response to changing of the perfusions. But the one I want you to pay attention is here. All this are for one reason. Do you see my arrow? Do you see my arrow? This is constant. You see this? This is constant. Look at the bottom. This is constant. All these hormones are released for one reason: to keep the GFR and autoregulation in the kidney constant. And sometimes based off the injury, it releases different amount of the hormones to make sure that these stay constant. The day that cannot keep it constant, it's going to be accelerated disease process. What did I tell you? The leading cause of kidney disease is diabetes. What's the second? Hypertension. 1 + 1, 11. You got it wrong. Okay, 10. Why? Because the auto-regulation is gone. It didn't become 2. When the auto-regulation is gone, it's going to be the constant injury to the kidney. So really, it becomes more like a speed. You know, it's just like a speed. The kidney is on a speed and just going through the degradation very, very quickly. And the GFR start declining very rapidly and end up on the dialysis. Now, angiotensin II is extremely important. Angiotensin II is extremely important because angiotensin control that renal blood flow. And I will show you in a second how it does it. But the function of the angiotensin is increase of GFR. When the kidney cannot sense it, it's nothing perfusing, the body make a lot of angiotensin II. And angiotensin II cause vasoconstriction and increased glomerular pressure, which is terrible for the kidney. This kidney is already stressed. With increasing the perfusion, you make more damage to the kidney. So you don't want to continue. It's like you have something down, you're constantly kicking it. That's the same concept. But you're wondering why the body does that. Well, it's a compensatory mechanism. Because I told you, kidney give up very fast in order to save everybody else. What it's going to say is, heart is failing, heart is not pumping, I don't want any perfusions. Let's cause a vasoconstriction, keep all the fluid around. In fact, long-term is harmful because those fluids going to go to the lung and cause a lot of dyspnea. So angiotensin is extremely important to causing that vasoconstriction. Of course, epinephrine and norepinephrine, they really increase the pressures. And that's the reason beta blocker is very helpful for patients who have a chronic kidney disease. Same as ACE inhibitor, because they block that pathways. AMP, from another hand, is renal protective. Renal protective. It causes vasodilations. Make sure there is not enough injuries to the kidneys. And of course, prostaglandin, very, very important, especially when you pass 70 years old, because that becomes a driving factor. We should never consider use of NSAID in old people because of it can cause a lot of acute kidney injury long-term from the use of those medications. So how does it do it? We don't know. Not because I was lazy, I didn't want to look it up and before coming to this lecture. Literally, we don't know. There's two concepts. One is based on pressure inside the kidney, that when there is so much pressure, it releases all the vasodilators. With the increase in vasodilators, you're decreasing the pressure inside the kidney, and it keeps the pressure constant through all time. More and more people believe is based of hypo and hypernatremia in macula densa. It's a sensing amount of the sodium. But the end is the same. End is the same. But what is triggering it, we are not sure which one. Or maybe it's both of them at the same time. Maybe it's the pressure and the sensins. Maybe they complement each other. But they do both, they do the same thing. When there is not enough flow to the kidney, they increase angiotensin. When there is excessive amount of the flow, they release adenosine that causes decreasing of the angiotensin. One more time. When there is not enough flow to the kidney, when there's not enough flow, they release angiotensin. When there is excessive amount of the flow, they release adenosine and they inhibit the angiotensin. As a result of that, you get the vasodilations. So it decreases the pressure. The whole idea, I have said it like 50 times now, is this. You see this? This is the most important part. To keep the GFR constant. To keep GFR constant. They are just a membranes or filter. Can you imagine you take one of the filter at your home and dump a bunch of junk over it? It's working all the time. Very soon it's going to fall apart. But you're keeping it constant, that filter stays safe and work forever. But that's the reason hypertension and diabetes can affect it. Now, what diabetes does, it actually causes destructions, all the glomeruli called acetylations. We call them A1Cs. It does the same thing, and you end up having the injuries to the kidney, and you have this massive amount of the flow that is going through. So the combination really changed the auto regulation of the kidney. As a result of that, you have so much problems in there. This is basically what I just talked about. Based off the flow and the pressure, it has angiotensin and we have adenosines. Adenosine has more vasodilatory effect, angiotensin have more vasoconstrictions effect. When the flow is low, you want an increase of renin, angiotensin, aldosterone, ADH pathway. When the flow is high, you want to decrease angiotensin because it's already feel the pressure. I got to decrease the pressure. With the release of adenosine and releasing the decreasing amount of the angiotensin, you're controlling that GFR stay constant through the days. Which of the following best describe the relationship between renal blood flow, mean arterial blood pressure, and other regulatory zones? Okay. Increased flow when mean arterial blood pressure is increased. Anybody? Just say no. Increased flow when mean arterial pressure is decreased. Decreased flow when mean arterial pressure is decreased. Constant flow regardless of changes of mean arterial blood pressure. What's the correct answer? D. You're lucky. The P3s, they always bring their cards. They have to take it out. So I'm not asking you to do it. But when you come P3, you all have a Cardex. You have to show it to me in the class. So what is the correct answer? And the correct answer in here is D. Keep it constant. Literally, I've said it like 10 times now. But this is number 11. Has to keep it constant. All this other regulation does the one thing, to keep the GFR. Which of the following will be released after high concentration of saline is sensed by macula densa? Does your renin increase or decrease? Decrease, beautiful. Angiotensin, decrease. Angiotensin 2, decrease. Aldosterone, decrease. What does it increase? Adenosine, the vasodilators will be increased in those patients. So why do we care about angiotensin? Besides the effect on the kidney, it affects every part of your body. Mostly effect on the heart. That's the biggest effect of the drug. With angiotensin cause hypertrophy. Are you following me? What is the shape of the heart? It's like a football, right? That's the shape of the heart. You throw the football, how far does it go? 100 yards. You better watch the game tonight. W, not the M, that's the wrong way. W, Pac-10. The size of, how far can you send basketball? Not even 1/3, not even 1/4. Why? Because it's balloon. The heart can squeeze. When it become hypertrophy, become big, when the size of the, most of you guys are sitting, this is the size of your heart. The patient who have cardiovascular disease, this is the size of their heart. They're big. So that big is come because they're hypertrophy. And angiotensin causes hypertrophy. When it's a hypertrophy, it cannot squeeze anymore. That's the reason ACE inhibitor not only is good for the kidney, they're good for the heart. And if all the patients with kidney disease die from cardiovascular disease, it makes sense to use angiotensin receptor antagonist or ACE inhibitor on patients who have chronic kidney disease. Decrease the pressure, decrease production of angiotensin, and protect their heart. That's the reason you use ACE inhibitor. Now, if they develop and they're on dialysis, doesn't matter, the kidney is gone. Still, you can protect their heart. ACE inhibitor still is protecting their heart, but it's not going to protect the kidney anymore because the kidney is gone and there's nothing you can do in there. Now, another problem with angiotensin is activate aldosterone. What is the function of aldosterone? I told you already, every species has it. Aldosterone job is to hold on sodium. What else? Wow, so cold water, cold chloride. And already somebody who has a heart failure cannot breathe, you're drowning them in the water. Literally, you're getting their head and shoving it in the water. It's called compensatory mechanism. So not only angiotensin has a side effect on the kidney and heart, it causes volume retention because it activates aldosterone. When aldosterone is activated, angiotensin activated, ADH get activated, antidiuretic hormones, and you will hold more water. They're all compensatory mechanism, but unfortunately, it's a bad compensatory mechanism. So everything we do trying to interfere with this compensatory mechanism because auto-regulation is gone. By the time you detect those two patients we have, the auto-regulation is gone. So all the drug we use in heart failure, on the kidney disease, trying to interfere with that compensatory auto-regulations. That is gone. And we will talk about those drugs tomorrow. Any questions so far? Any question? But tomorrow is through the WebEx, right? Tomorrow you have lecture, right? From 12 to 1, right? You're scaring me, guys. Holy cow. Okay, tomorrow we have lecture from 12 to 1. Wednesday, 12 to 2, 4 to 6. Are you following me? That's not optional. That's not optional. That's a real class. Thursday, we have a class. Friday, we have optional. And are you clear about this week? Nobody gonna send me a message, I forgot we have a class tomorrow. Who's the class president? Do we have one? Yeah. Oh, you are? Just make sure everybody knows. You're good. No question?